Welcome to the Deep Dive, your ultimate shortcut to truly mastering complex information. Today, we're not just scratching the surface. We are plunging headfirst into one of the most intricately orchestrated, profoundly impactful, yet often underestimated systems in your body, the thyroid system. Our mission today is really to go beyond the basics, to immerse ourselves in every single topic, every concept from our source material, GOODMAN and GILMAN's The Pharmacological Basis of Therapeutics.
Right, a foundational text.
Exactly. We want you to walk away feeling like you've achieved a level of understanding like the elite professionals in this field. We're talking surprising facts, practical insights, and those, satisfying aha moments.
Getting that deep clarity.
That's the goal. So if you're ready, let's unpack this incredibly complex and fascinating system that, well, it literally influences almost every single part of you.
Let's do it.
So let's begin our journey right at the heart of it. At its core, the thyroid gland plays an absolutely fundamental role in our bodies.
Absolutely essential.
It's this small gland, shaped a bit like a butterfly, nestled there in your neck. Easy to overlook, maybe.
Physically small, yeah. But functionally huge.
Enormous impact. Think about this. Thyroid hormone is essential for normal development, especially of your central nervous system, the CNS.
Brain and spinal cord. Crucial early on.
We're talking the very fabric of your brain development. Without it, particularly in early life, the brain it cannot develop properly. It's really that critical.
It lays the groundwork.
And its work doesn't stop there, does it? In adults, thyroid hormone is key to maintaining what we call metabolic homeostasis.
Right, keeping things stable, energy balance.
It's a bit of a fancy way of saying it keeps your body's energy balance and internal environment stable, making sure everything runs smoothly. But its influence, it stretches far beyond just your metabolism.
Oh, far beyond. It affects virtually every organ system you can name.
It's like, imagine a tiny conductor, incredibly precise, leading this massive, complex symphony orchestra.
Yeah, that's a good analogy.
Ensuring every instrument plays in harmony, every section comes in at the right time, the whole performance, a masterpiece of coordination.
That's pretty much what your thyroid gland does for your entire body. It's the orchestrator.
Yeah.
And what's truly fascinating here, I think, is the sheer ingenuity of how the body evolved this system, managing such a critical element.
How so?
Well, thyroid hormone contains iodine, right? Which is an absolutely crucial nutritional requirement. We have to get it from our diet.
Right, the body can't make it.
Exactly. And the thyroid gland, it isn't just a simple factory producing hormone on demand. It's also a really sophisticated storage facility.
Storage. How's that work?
It stores large quantities of hormone, but in a precursor form bound up in this big protein called thyroglobulin.
Ah, okay.
Think of it like a massive biological reservoir. And this remarkable storage system allows your body to maintain incredibly stable concentrations of thyroid hormone systemically, even when there are significant ups and downs in your iodine intake or, other nutritional factors.
So it buffers things, like having a deep well during a drought.
Precisely. It ensures that steady, reliable supply of this vital element no matter what. It's a brilliant biological buffer system.
Okay, so when we talk about thyroid hormones, there are two main players, right? T4 and T3.
That's right. The thyroid predominantly secretes T4, thyroxine.
But here's the crucial point, as I understand it. T4 isn't the main actor, is it? It's more like a prohormone.
Exactly. It primarily acts as a prohormone. It's not fully active in that form. It travels through your bloodstream and gets converted.
Where does the conversion happen?
In various peripheral tissues, your liver, your kidneys, even your brain. They convert it into T3, or 5003 iodothyronine.
And T3 is the active form.
T3 is the truly active form, yes, the one that directly interacts with your cells to exert its effects.
Okay, but here's where it gets really interesting. And this shows that incredible layer of precise control we want to master. This local activation, T4 into T3, and even deactivation of T3. It doesn't just happen randomly in big organs, does it?
No, not at all. It occurs directly within the specific target tissues where that hormone action is needed most, like within brain cells themselves or the pituitary gland.
So not just converted somewhere else and shipped out, it's on-the-spot regulation.
Exactly. This local fine-tuning mechanism, it's increasingly recognized as an incredibly important step for achieving exact control of thyroid hormone action right down to the cellular level, making sure each cell gets precisely the signal it needs when it needs it.
Wow, that level of precision is, well, it's astounding.
It really is. And if we connect this to the bigger picture, the concentrations of these hormones circulating in your blood are kept within an incredibly tight physiological range.
Oh, what keeps it so tight?
It's managed by a sophisticated negative feedback system involving that key pituitary hormone, TSH, thyroid stimulating hormone.
Okay, TSH.
Think of it like a perfectly calibrated thermostat. When your thyroid hormone levels are just right, maybe a little high, that signal travels back to your pituitary gland.
Telling it to back off.
Exactly, telling it to reduce TSH production. But if your thyroid hormone levels start to drop,
The pituitary ramps up TSH.
precisely, it gets the message to ramp up TSH production, which then stimulates the thyroid to make more hormone. It's a beautifully balanced, responsive system designed for optimal levels.
Okay, and the actions themselves, they're not just a general metabolic boost, right? You said they're specific.
Incredibly specific. The predominant actions are primarily mediated when T3 binds to special structures inside your cells called nuclear thyroid hormone receptors, or TRs.
Inside the nucleus.
Yes. These receptors then modulate the transcription of specific genes.
So it's controlling genes directly, not just pushing general buttons.
Exactly. It's influencing which genes are turned on or off in your DNA, dictating precise cellular functions and processes at a fundamental genetic level. This whole system, the negative feedback, the gene modulation, it's a prime example of biological fine-tuning, ensuring balance, preventing excess or deficiency, just exquisite control of your body's most basic functions.
Incredible. Okay, moving from that grand orchestration, let's zoom in on this specific chemical players, the hormones themselves.
Right.
The main ones, the iodothyronine hormones, T4 and T3, they come from the thyroid follicle, the main functional unit.
Correct.
But there's another hormone people might hear about sometimes, calcitonin.
Ah, yes, calcitonin. It's a 32 amino acid peptide produced by different cells in the thyroid, the parafollicular cells.
Is it a major player in thyroid function?
Well, it's important to clarify that in adults, calcitonin is not considered a major player in the everyday regulation of thyroid function itself.
But it has other uses.
Yes, it can be quite useful therapeutically for specific conditions like hypercalcemia, that's excessively high calcium levels, or in managing osteoporosis.
Okay, so different role. For a deeper dive on calcitonin, you'd look elsewhere the source. Our focus today stays on T4 and T3.
Exactly. The iodothyronines are central to the story.
Now, let's take that quick journey back in time. The discovery of T4 and T3. It's quite insightful, isn't it, about how science works.
It really is a great example of peeling back layers.
Initially, when T4 was isolated, back in the early 20th century, the thinking was, that's it. T4 accounts for all thyroid activity.
Right. Seemed logical at the time. We found the active hormone.
But then, here's where it gets really interesting. Scientists started noticing something odd.
Discrepancies.
Careful studies began showing that crude thyroid preparations, like less refined extracts from the gland tilly, they actually had greater calorogenic activity.
Meaning they boosted metabolism more than expected.
Exactly. More than could be explained by their T4 content alone. That sparked a big debate, didn't it? Could there be a second thyroid hormone?
A hidden player. And indeed there was. T3 was finally detected, isolated, and synthesized by Gross and Pitt Rivers in 1952.
A truly revolutionary discovery.
Absolutely. Changed everything.
And the key difference that came out of that discovery, the thing that revolutionized understanding and treatment, was T3's affinity for the receptor.
Yeah, precisely. T3 has a much, much higher affinity for that nuclear thyroid hormone receptor, the TR, compared with T4.
So in practical terms,
Yeah.
more potent.
Significantly more potent biologically on a molar basis. It packs a far greater punch for its size. This later discovery really reshaped how we understood thyroid hormone action at the cellular level, and importantly, how we approach treatment. Recognizing T3 as the true biologically active form driving most effects.
And that deep understanding then directly informs how we look at the clinical side, the manifestations of thyroid dysfunction.
Exactly. When you have an excess overt hyperthyroidism or a deficiency overt hypothyroidism, both present with a whole host of distinct clinical signs and symptoms affecting virtually every system.
But milder forms can be tricky.
Very tricky. Milder forms often have much subtler presentations. They might only be picked up through abnormal biochemical tests, blood work. The person might not even feel overtly sick yet.
Right. So testing is key.
Critical. And speaking of clinical impact, one area that absolutely demands attention is maternal and neonatal hypothyroidism, especially when it's due to iodine deficiency.
You mentioned its link to intellectual disability.
Yes, it remains a major preventable cause of intellectual disability worldwide. This isn't just a minor health issue, it's a profound global health challenge.
But the good news amidst these challenges.
The good news is that the vast majority of thyroid disorders, whether deficiency or excess, can be either cured or effectively controlled with modern medicine.
How so? What are the main approaches?
Well, for hypothyroidism, it's primarily thyroid hormone replacement, usually with synthetic T4 levothyroxine.
Replacing what's missing.
Exactly. And for hyperthyroidism, the approaches are varied but effective. You've got antithyroid drugs that decrease hormone production and secretion. Then there's radioactive iodine, which selectively destroys the overactive gland tissue.
A targeted approach.
And in some cases, surgical removal of the thyroid is the best option. The key takeaway is that most people with thyroid disorders can lead full, healthy lives with proper diagnosis and management.
Okay. And what about thyroid malignancies? Cancers?
That's another important area. The good news there is that thyroid malignancies are most often localized and resectable.
Meaning they can be surgically removed and are often confined?
Correct. And if the disease has spread, metastatic disease, it often responds quite well to radioactive iodine treatment, again, leveraging the thyroid's unique ability to take up iodine.
But what if it doesn't respond to radioactive iodine? Those refractory cases.
Right. For those challenging cases that are radioiodine refractory and are progressive, continuing to grow, modern medicine has made significant strides.
Like targeted therapies.
Exactly. These more aggressive cancers may now respond to newer targeted chemotherapies, specifically drugs known as tyrosine kinase inhibitors. They offer a new and increasingly effective avenue for treatment when traditional methods aren't enough.
That's encouraging. Okay, now that we've got the hormones and their broad impact, let's unpack the truly amazing choreography of how these vital hormones are actually made and processed.
Yes, the biosynthesis. It's a marvel of biological engineering.
A multi-step dance.
Yeah.
To really master this, we need to visualize it, almost like following a detailed diagram.
It's intricate.
So where does it begin?
Well, at the very heart of it, thyroid hormones aren't just floating around free. They're synthesized and stored as amino acid residues within this massive protein called thyroglobulin.
Thyroglobulin, that's the big storage protein?
That's the one. It's a large, complex glycoprotein, and it forms the vast majority of the thyroid follicular colloid, that gel-like stuff in the center of the thyroid follicles.
And you said the thyroid is unique in how it stores hormone.
It really is. Compared to almost any other gland, its ability to store such vast quantities of hormone precursor in this extracellular way is remarkable. The amount of this thyroglobulin is directly proportional to the thyroid's mass. It's essentially a huge, ready-to-go reserve tank.
Incredible. Yeah, let's meticulously break down the specific steps. Biosynthesis, storage, release, interconversion.
All right, step one.
Step one. Uptake of iodide. It all starts with iodine in your diet, right? Reaches the blood as iodide ion, usually a low concentration.
Very low, yes. Then the thyroid acts like a highly efficient vacuum cleaner.
How?
It actively transports this iodide into its cells using a specific transporter protein on the cell membrane called the sodium iodide symporter, or NIS.
NIS. And it's efficient.
Incredibly efficient. The thyroid can concentrate iodide inside its cells to levels 20 to 50 times higher than plasma. And when stimulated, that ratio can exceed 100.
Wow. Can anything block this?
Yes, other ions that mimic iodide, like thiocyanate and perchlorate, can inhibit it. Interestingly, TSH, that pituitary hormone, actually stimulates the expression of the NIS gene and helps insert more NIS pumps into the membrane.
So TSH ramps up iodine uptake.
Right. If your iodine stores are low, TSH goes up, enhancing uptake. Conversely, a large dose of iodide can actually decrease NIS protein expression, a feedback mechanism.
And NIS isn't just in the thyroid.
No, other tissues use it too. Salivary glands, gut, the lactating breast, they all accumulate iodine via this single NIS gene, which explains why people born with mutations in the NIS gene can't concentrate iodine effectively in any of those tissues.
Okay, so iodide is inside the cell. What's next? Step two, oxidation and iodination, organification.
Right. First, the iodide needs to get from the follicular cell into the colloid, the storage area. Another transporter called pendrin helps with that.
Pendrin.
But just getting there isn't enough. The iodide needs to be activated. This crucial step, the oxidation of iodide to its active form, is done by a key enzyme, thyroid peroxidase.
Thyroid peroxidase sounds important.
Absolutely critical. This enzyme enables the formation of monoiodotyrosine, MIT, and diiodotyrosine, DIT residues within that big thyroglobulin protein. This whole process of incorporating iodine into an organic molecule is called organification, and it happens right before storage in the follicle lumen.
Okay, MIT and DIT are now on the thyroglobulin. Step 3, formation of T4 and T3 from iodotyrosines.
Now comes the coupling step. Two DIT residues combine to form T4, or one MIT and one DIT residue couple to form T3.
And thyroid peroxidase is involved here too.
Yes, these oxidative coupling reactions are also catalyzed by thyroid peroxidase. It's central to synthesis. It's also worth noting that some T3 is generated right there in the thyroid by 5-saccharide deiodination of T4 before secretion.
Got it. So synthesis is done. Hormones are stored on thyroglobulin. How do they get out? Step 4, synthesis and secretion.
Proteolysis is key here, breaking down the protein.
How does that start?
It's initiated when the thyroid cell swallows tiny packages of colloid from the follicular lumen, process called endocytosis. A receptor called megalin plays a role.
Megalin.
These ingested thyroglobulin molecules form intracellular colloid droplets, which then fuse with lysosomes.
The cell's recycling centers.
Exactly. Lysosomes contain the proteolytic enzymes needed to break down the thyroglobulin, and guess what enhances this?
Let me guess. TSH.
You got it. TSH enhances thyroglobulin degradation by increasing the activity of these lysosomal enzymes. Finally, the liberated hormones, primarily T4, along with some T3, exit the cell and enter the bloodstream.
An incredibly intricate process. So after all that, what are the actual numbers we see circulating? Let's get quantitative.
Good idea. Daily production. T4 is around 80 to 100 micrograms. T3 is much lower, maybe 30 to 40 micrograms.
And in the plasma?
Total T4 concentration is roughly 5 to 12 micrograms per deciliter. Total T3 is significantly less, maybe 80 to 175 nanograms per deciliter. Tiny amounts.
But the key thing is the free hormone, right? The unbound stuff.
Absolutely crucial. The non-protein bound or free fraction of T4 is minuscule, around 0.02%. For T3, it's a bit higher, about 0.3%.
We're getting a difference.
It's mainly because the main carrier protein, thyroxine-binding globulin or TBG, holds onto T4 much more tightly than T3.
Ah, higher affinity.
Much higher. And this difference in binding also affects half-life. T4 has a long plasma half-life, about 7 days. It sticks around. T3 is much shorter-lived, roughly 20 hours.
So different kinetics entirely. These numbers give a real sense of the tiny yet potent quantities at work.
Which brings us right to that crucial concept, the free hormone concept.
Right. Only the unbound hormone is active.
Exactly. Only that tiny circulating fraction not clinging to transport proteins is biologically active, has metabolic effects.
And the implication of that?
It means that changes in the concentration of those plasma transport proteins, like TBG, or even subtle shifts in their binding affinities, can significantly alter the total serum hormone levels.
Even if the active free hormones stay stable.
Correct. Which raises an important question for anyone interpreting labs. Why do different drugs and conditions alter hormone binding?
Like estrogens, pregnancy.
Exactly. Estrogens, whether from pregnancy, birth control pills, or drugs like tamoxifen, can increase TBG, leading to higher total levels. But things like corticosteroids or certain anti-seizure meds can decrease binding, lowering total levels. Liver disease also messes with protein levels.
So just looking at total levels can be really misleading.
Absolutely. Understanding the free hormone concept is paramount for accurate diagnosis and management. You have to know what you're measuring and why.
Okay, so the hormones do their job, then they need to be broken down and excreted. How does that happen?
It's not just snipping off iodine atoms, though deiodination is key. T3 and T4 can also be metabolized through more complex processes,
Right.
ether cleavage, conjugation, oxidative decarboxylation.
Various chemical
Oh,
modifications.
let's see. Right. And T4 is eliminated relatively slowly. Remember that 6 to 8 day half-life,
Longer than T3.
which shortens in hyperthyroidism, maybe 3-4 days, and prolongs in hypothyroidism, maybe 9-10 days. Things that increase TBG binding, like pregnancy, also slow its clearance.
And T3. Much faster clearance.
Much faster. Half-life around 18-24 hours because it's less avidly bound. The liver is the major site for non-deadenative degradation. T4 and T3 get conjugated chemically tagged with glucuronic and sulfuric acids and then excreted in the bile.
Into the gut.
Into the gut. Some can be reabsorbed, but a portion makes it to the colon, gets hydrolyzed back to free compounds, and is eliminated in the feces. It's a continuous cycle.
Creation, action, elimination. Now, you mentioned deiodination peripherally. That's a huge part of the T3 story, isn't it?
Absolutely critical. While the thyroid secretes some T3 directly, a remarkable Roughly 80% of the circulating T3 in your bloodstream actually comes from that peripheral fibrodeadenation of T4.
So the body makes most of its active hormone outside the thyroid.
Exactly, converting the less active T4 into potent T3 in various tissues. But there's another type of deadenation, right? 5-ure-deadenation of the inner ring of T4.
Yes, that produces reverse T3 or RT3.
Which is metabolically inactive. It's essentially the body's way of deactivating thyroid hormone.
So there's activation and deactivation happening all the time.
It's a delicate balance. Normally, about 40% of T4 converts to active T3, roughly another 40% to inactive RT3, and the remaining 20% goes through those other metabolic pathways. Maintaining that balance is critical.
And the enzymes doing this, the diadases, Dio1, 2, and 3.
What's truly fascinating here is the pivotal role of these three specific iodothyronine diodeinases, Dio1, Dio2, and Dio3. They're the enzymes responsible for these precise conversions.
Okay, break them down for us. Dio1 and Dio2 make T3.
Right. Dio1 and Dio2 both convert T4 to active T3. Dio1 is found mainly in the liver, kidneys, thyroid, pituitary. Its activity actually goes up in hyperthyroidism and down in hypothyroidism, and it can be inhibited by that antithyroid drug propilyfluoroacyl PTU.
Okay, and Dio2?
Dio2 is expressed predominantly in the central nervous system, pituitary, hypothalamus, also brown adipose tissue, the thyroid itself, and lower levels in skeletal muscle, heart. Interestingly, its activity is not affected by PTU.
Different regulation.
And importantly, Dio2 is strategically located on the endoplasmic reticulum inside the cell, which facilitates direct access of the T3 it generates right to the cell nucleus.
So tissues with Dio2 get a local T3 boost.
Exactly. They can use locally generated T3 in addition to plasma T3, allowing for high occupancy of their thyroid hormone receptors. Ensures these critical tissues get precisely the hormone signal they need.
The regulation of Dio2 sounds complex too.
It is. T4 itself can actually induce the degradation of the Dio2 enzyme. So in hyperthyroidism, Dio2 levels are suppressed, while in hypothyroidism, they're elevated. It's another layer of homeostasis, trying to keep T3 levels stable. T3 itself can also mildly repress Dio2 gene expression.
How much T3 comes from each?
It's tricky to pin down exactly, but current estimates suggest Dio1 accounts for maybe a third, and Dio2 for about 2/3 of circulating T3 in euthyroid individuals. But because of their different regulation, Dio2 likely contributes more in hypothyroidism, playing a compensatory role, while Dio1 becomes the majority contributor in hyperthyroidism.
Interesting. And there's a genetic variation in Dio2, the thionamide allopolymorphism.
Yes, that's worth mentioning. This variation is associated with reduced enzyme activity, seems to cause stress in the ER and accumulation of inactive enzyme.
Does it have clinical effects?
Well, some smaller studies have linked it to things like increased BMI, insulin resistance, maybe lower free T3 levels in patients on levothyroxine, and even differences in psychological well-being, with some reporting feeling better on combination T4-T3 therapy.
But it's not fully confirmed.
Crucially, other studies have not confirmed these findings, so the overall significance of Dio2 polymorphisms in human health and disease, it remains to be fully clarified. It's an active area of research. It definitely raises that important question about personalized therapy, doesn't it? Can we tailor treatment based on genetics?
A key question for the future. Okay, what about Dio3?
Dio3 catalyzes the inner ring, or 5-deadenation. This is the main inactivating pathway for T3 metabolism. Dio1 also contributes to inactivation, but Dio3 is the primary player.
Where is Dio3 found?
Highest levels are in the CNS and the placenta, also skin, pregnant uterus. Interestingly, it can be induced locally by inflammation and hypoxia, and it's highly expressed in some tumors.
So it plays roles in development too.
Critical roles. Both Dio2 and Dio3 are expressed in very specific time and spatially restricted patterns during development, precisely regulating local T3 levels for processes like brain formation, limb growth, really guiding development.
And all three diodeinases rely on something unusual.
Yes, they all contain a rare amino acid called selenocysteine in their active sites, absolutely vital for their function. Mutations in a protein involved in incorporating selenocysteine, thus as binding protein 2, are associated with abnormal thyroid hormone levels. Just underscores the delicate complexity of it all.
Selenocysteine, another layer of complexity.
Mm-hmm.
Okay, we've gone through synthesis, metabolism, the enzymes. Now let's turn to the master regulators orchestrating secretion, TSH, TRH, that whole feedback loop.
Right, the central command system.
The main player here is thyrotropin, TSH. Thyroid-stimulating hormone. It's a glycoprotein.
Yes, protein with sugar molecules attached. 2 subunits, an alpha subunit, which is actually common to other pituitary hormones like gonadotropins, and a unique beta subunit that gives TSH its specific thyroid-stimulating function.
And it's secreted in a pattern.
Yes, it's pulsatile, secreted in bursts, and follows a circadian pattern, typically slightly higher during sleep at night. Interestingly, this pattern is inversely related to your body's cortisol rhythm. Cortisol actually reduces TSH secretion.
How is TSH itself regulated?
It's a finely tuned system, controlled primarily by a hypothalamic peptide called TRH, thyrotropin-releasing hormone.
From the hypothalamus.
Right. And crucially, by the concentration of free thyroid hormones circulating in the blood. That's the negative feedback.
Thermostat again.
Exactly. Increased thyroid hormone inhibits the transcription of both the TRH gene in the hypothalamus and the TSH subunit genes in the pituitary. This suppresses TSH, causing the thyroid gland to become less active, even regress slightly.
And if thyroid hormone drops?
The opposite happens. Decreased thyroid hormone evokes enhanced TSH secretion, stimulating the thyroid to produce more. There are also other subtle mechanisms, like reduced TRH secretion itself and fewer TRH receptors on pituitary cells, all part of this intricate regulatory ballet, designed for precision. And to really go deep into this, that thyrotropin-releasing hormone, TRH, it's just a small tripeptide, synthesized by neurons in your hypothalamus.
A key brain control center.
Release into a special blood vessel network, the hypophyseal portal circulation, which directly connects the hypothalamus to the anterior pituitary.
So it travels straight there?
Straight there. Binds to its specific receptors, which are G-protein-coupled receptors, GPCRs on the thyrotropin cells in the anterior pituitary.
And triggers TSH release.
Triggers a specific intracellular signaling cascade. GQ-PLC-IP3CO2 plus pathway activates protein kinase C. The intricate result is robust stimulation of both TSH synthesis and its release.
Complex signaling.
Very. We've actually identified two distinct TRH receptors, TRH-R1 and R2. Scientists are even developing receptor-selective TRH analogs, which could offer potential for highly targeted therapies down the road.
Anything inhibit this?
Yes. Other hormones like somatostatin, dopamine, and glucocorticoids can inhibit TRH-stimulated TSH secretion, adding more layers to the regulation.
Okay, so TSH reaches the thyroid gland. What are its direct actions there?
TSH directly and powerfully increases both the synthesis and the secretion of thyroid hormone. It binds to its own GPCR on the thyroid cell plasma membrane. This primarily stimulates the G-adenylycyclic AMP pathway, a major intracellular signaling route. Interestingly, at higher TSH concentrations, it can also activate the GQ-PLC pathway, shows a dose-dependent effect.
And this receptor is clinically important.
Hugely important. Both inactivating mutations leading to underactivity and activating mutations leading to overactivity or hyperthyroidism of the TSH receptor have been identified. They can directly cause thyroid dysfunction just by altering how the thyroid responds to this critical pituitary signal, like having a broken thermostat stuck on or off.
Right. Now, iodine, its role is so critical, it bears repeating and maybe a deeper look.
Absolutely fundamental, cannot overstate it. Adequate iodine intake is essential for normal thyroid hormone production, period.
What happens when intake is low?
Hormone production is reduced. In response, your body secretes excess TSH. This stimulates the thyroid gland, causing hyperplasia, more cells, and hypertrophy, bigger cells, that's goiter, and enlarged thyroid.
And the gland works harder to compensate.
Exactly. This enlarged, stimulated thyroid becomes remarkably efficient at extracting even tiny traces of iodide from the blood, developing an iodine gradient maybe 10 times normal.
Can it compensate enough?
In mild to moderate deficiency, often yes. The thyroid might preferentially secrete T3 to make up for lower T4, but in severe iodine deficiency, the consequences can be dire. Adult hypothyroidism, or that tragic congenital iodine deficiency syndrome we mentioned.
And too much iodine, also a problem.
Yes. High levels can inhibit T4 synthesis and release the Wolff-Chaikoff effect, highlights the delicate balance. Too little is bad, too much can also be problematic.
Historically, goiter was common due to deficiency. How was that addressed?
The most practical public health measure is adding iodate to table salt. Provide small, consistent supplements. In the U.S., iodized salt typically has about 100 micrograms of iodine per gram.
And there are recommended daily allowances.
Yes, carefully established. 120 micrograms for kids, 150 for adults, 220 during pregnancy, 290 during lactation, reflecting increased needs.
Food sources.
Veggies, meat, poultry are generally low. Dairy products and fish are relatively higher, offering dietary sources.
Okay, so we've got hormones made, regulated, transported in the blood. But how do they actually get into and out of the cells to work? You mentioned transporters.
Right. This passage across cell membranes isn't passive. It's mediated by specific dedicated transporters. The most well-documented include MCT8, MCT10, OATP1C1, and SLC17A4. Understanding these is key to the full picture.
Let's start with MCT8.
Okay. MCT8 is widely expressed throughout the body, including critical brain regions.
And mutations cause problems.
Severe problems. Mutations in the MCT8 gene cause Allan-Herndon-Dudley syndrome, profound neurodevelopmental defects, very likely due to impaired T4 and T3 entry into the brain, essentially starving the brain of thyroid signals.
What else is seen in this syndrome?
Often low circulating free T4, elevated free T3, sometimes even signs of thyrotoxicosis in peripheral tissues. It's a paradox.
Is there any treatment?
Interestingly, the T3 metabolite triac, or tiratricol, it's biologically active but doesn't need MCT8 for cell entry.
Workaround.
A potential workaround. A phase 2 trial showed triac improved signs of peripheral hyperthyroidism in these patients, though they were often too old for major neurodevelopmental improvement, underscores that critical early window.
What about OATP1C1?
Another important transporter, prefers T4 over T3, highly expressed in the brain. Animal studies show it's crucial for T4 transport across the blood-brain barrier.
Clinical impact.
A single patient described with homozygous OATP1C1 mutation had a severe neurodevelopmental phenotype. Remarkably, showed clinical improvement with triac therapy, again, bypassing the defective transporter.
And MCT10 and SLC17A4.
MCT10 transports T3 more effectively than T4, widely expressed. Yeah. SLC17A4 transports both, expressed in liver, kidney, intestine, pancreas. But their exact importance in precise regulation in humans and specific mutation phenotypes, that remains to be fully determined. An active, exciting area of ongoing research, uncovering the intricate ballet of hormone movement.
Okay, so they get inside the cell. What next? You mentioned the nuclear receptors, TRs.
Right. Once inside, the profound actions are largely mediated by T3 binding to these thyroid hormone receptors, or TRs.
Part of a bigger family, like steroid receptors.
Exactly. They're members of that large, important nuclear receptor superfamily of transcription factors. Includes receptors for steroids, vitamin D, retinoic acid, highlights a common regulatory strategy.
And their structure. How do they work?
They have a classic structure. Amino terminal domain, a central zinc finger DNA binding domain, that's what grabs the DNA, and a ligand binding domain in the carboxyl terminal half, where T3 actually binds.
And T3 binds much more tightly than T4.
About 10-fold greater affinity. For practical purposes in normal physiology, T4 is generally not considered biologically active itself. It's the precursor. T3 is the key.
So T3 binds, then what?
The TRs then bind to specific DNA sequences called thyroid hormone response elements, or TREs, in the promoter regulatory regions of target genes.
Turning genes on.
Well, when unliganded, without T3 bound, TRs actually act as repressors for most target genes, keeping them turned off.
Okay, so T3 binding releases the brakes.
Precisely. T3 binding causes a conformational change, replaces a copressor complex with things like histone deacetylases with a coactivator complex, bringing in histone acetyltransferases, methyltransferases. This fundamental shift induces transcription, turning the gene on.
But some genes are turned off by T3.
Yes, genes like those for TRH and the TSH subunits are negatively regulated by T3. That's part of the feedback loop, maintaining balance.
Are there different types of TRs?
Yes, two primary genes encode them, THRA and THRB.
THRA.
Encodes primarily TRAIN1, expressed in most cell types. Major activities in regulating heart rate, body temperature, skeletal muscle function, and development of bone and the small intestine.
Mutations cause problems here too.
Yes. THRA mutations lead to resistance to thyroid hormone alpha, characterized by short stature, bony abnormalities, chronic constipation, usually with normal TSH and low normal T4 levels.
And THRB.
Has two promoters, produces TR1 and TR2 isoforms, unique amino terminal domains, otherwise identical core structure, ubiquitous. Mediates many systemic effects, particularly in liver metabolism, like the cholesterol-lowering effect of T3.
And TR2, more specific.
Highly restricted expression, pituitary hypothalamus mainly. Crucial roles in that negative feedback loop of T3 on TRH-TSH. Also vital for developing retinal cones, vision, and the inner ear hearing.
And mutations in THRB.
Cause resistance to thyroid hormone beta. Different clinical picture. Goiter, tachycardia, impaired hearing, ADHD sometimes. Labs typically show elevated T4 and T3, with TSH often mid to high, normal, or even frankly elevated, a distinct biochemical signature.
Okay, so thyroid hormone works mainly through these nuclear receptors controlling genes,
Yeah.
but you mentioned non-genomic effects,
Yeah.
actions outside the nucleus.
Yes, this is a fascinating and evolving area. Beyond the traditional nuclear receptor action, TRs are also found outside the nucleus where they can exert rapid, non-genomic biological effects.
How does that work?
Well, for instance, a truncated form of TRI1, chemically modified by palmitoylation, actually localizes to the plasma membrane, the cell surface.
On the edge of the cell.
Right there. And it causes rapid T3-dependent nitric oxide NO production, vital for blood vessel dilation and activation of key signaling pathways like ERK and ACT, involved in cell growth and survival.
Even full-length receptors.
Yes, full-length TRI1 and TRI1 have been reported to associate, in a T3-dependent way, with a subunit of PI3K, which results in activation of ACT.
Clinical connection. You mentioned vasodilation.
Exactly. T3 administration is known to cause rapid vasodilation. This could potentially be explained by this NO generation at the cell membrane.
Is there strong evidence for these non-gene effects?
Perhaps the strongest in vivo evidence comes from mouse studies. Mice with TR genes mutated so the receptors couldn't bind DNA in the nucleus. Even in these mice, T3 could still regulate heart rate, body temperature, blood glucose, triglycerides. Strong evidence for significant actions beyond genetic modulation.
Any other pathways involved?
There's some evolving evidence for actions via a plasma membrane receptor within integrin AVA3. This seems to bind T4 preferentially over T3 and activates MAP kinase. But the precise importance of this particular pathway, still uncertain. Ongoing discovery.
So what does this all mean? The thyroid isn't just sending signals to your genes for long-term changes, it's also making rapid, immediate adjustments right at the cellular membrane. Mind-blowing.
It adds another layer of complexity and responsiveness to the system.
Okay, let's broaden the scope again. What are the major clinical effects of thyroid hormones across the body? Their reach is astonishing, right?
Absolutely essential to grasp this. Most cells and organs respond. Thyroid hormone regulates a vast array of physiological processes underpinning nearly every system's optimal function. Truly pervasive influence.
Let's dive into specifics. Growth and development first.
Right. The classic example is amphibian metamorphosis. Tadpole to frog, limb development, lung development, tail regression, all intricately driven by T3.
Dramatic. But for humans?
Yeah. Even more critical, profound, vital, irreplaceable role in brain development. Mechanisms still incompletely understood, but its absence during active neurogenesis, up to about 6 months postpartum, leads to irreversible intellectual disability.
What goes wrong in the brain?
Multiple morphological alterations, disturbed neuronal migration, deranged axonal projections, decreased synaptogenesis. The brain's wiring just gets messed up.
But there's hope if caught early.
Crucially, yes. Thyroid hormone supplementation, if started within the first 2 weeks of postnatal life, can actually prevent these severe morphological changes, allows for normal brain development. The devastating defects in untreated congenital hyperthyroidism vividly illustrate how indispensable thyroid hormones are for normal human development.
You mentioned congenital iodine deficiency syndrome or cretinism. How does that present?
It can be endemic due to severe iodine deficiency in a region, or sporadic from abnormal thyroid development or a genetic defect. The affected child often appears normal at birth, which is the challenge.
So symptoms appear later.
Yes. Decreased growth, short extremities, intellectual disability, listlessness, puffy face, enlarged tongue, dry, doughy skin, slow heart rate, constipation, decreased body temperature.
Treatment needs to be immediate.
Absolutely. Diagnosis shortly after birth, prompt T4 treatment, long before these signs become apparent, is crucial for full effectiveness. In endemic areas, iodine replacement before pregnancy is recommended. This is precisely why newborn screening for thyroid function is such a critical public health initiative in industrialized countries. It changes lives.
A simple test with profound impact. Okay, what about the skeleton?
In childhood hypothyroidism, you see decreased linear growth, delayed bone age, and epiphyseal dysgenesis, abnormal development at the ends of bones.
Similar to that THRA mutation syndrome.
Exactly.
Yeah.
Largely mediated through TRIO1. Conversely, childhood thyrotoxicosis, excess hormone, can paradoxically decrease final height by accelerating bone maturation and causing premature fusion of the growth plates, shuts down growth too early. And in adults, thyrotoxicosis accelerates bone turnover, increasing osteoporosis risk, especially alongside postmenopausal estrogen deficiency.
Okay, thermogenesis. Heat production. A core function.
Essential for both obligatory thermogenesis, the heat from vital processes, and facultative or adaptive thermogenesis, generating extra heat when needed, like in the cold.
Most organs respond.
Most do. Exceptions are brain, gonads, spleen, generally unresponsive to direct thermogenic effects.
How does T3 make heat?
It essentially tells the body's energy factories to run a little hot, makes biological processes thermodynamically less efficient to produce heat.
Wasting energy for warmth.
Kind of. Involves multiple mechanisms. Futile cycling, changes in mitochondrial energetics, stimulating ion gradients like Na plus K plus and Fe2 plus site.
Is it sensitive?
Highly sensitive around the physiological range. Small changes in levothyroxine dose significantly alter resting energy expenditure in hypothyroid patients. And the body supports this T3, also stimulates appetite and lipogenesis, ensuring enough fuel for heat production, interconnected.
The cardiovascular system. Profound effects here too. Hyperthyroidism.
Typically tachycardia, rapid heart rate, increased stroke volume, increased cardiac index, overall output, often cardiac hypertrophy, enlargement, decreased peripheral vascular resistance, easier blood flow, increased pulse pressure, and importantly, a common cause of atrial fibrillation.
AFib, serious arrhythmia.
Yeah.
And hypothyroidism. The opposite.
Largely, yes. Bradycardia, slow heart rate, decreased cardiac index, pericardial effusion, fluid around the heart, increased peripheral resistance, decreased pulse pressure, often elevated mean arterial pressure.
What are the mechanisms behind these heart effects? Gene expression again.
Primarily T3 regulating myocardial gene expression through TRIA1, which is higher in cardiomyocytes.
What specific effects?
Increases diastolic relaxation, the heart's ability to fill, lusotropic effect, by inducing circuit-2 ATPase and decreasing its inhibitor, phospholamban. Increases contraction force, inotropic effect, partly by inducing the RIR2 calcium channel.
Faster contraction too.
Yes, enhances contraction velocity by inducing MHG, which has greater ATPase activity, and decreasing MH2. And the heart rate effect, chronotropic, involves increases in the pacemaker current, if with channel proteins like HCN2 and HCN4 induced by T3.
And the vasodilation effect, lower resistance.
T3 has a significant vasodilating effect on vascular smooth muscle, likely multifactorial. Includes rapid non-genomic stimulation of endothelial NO production, contributing to that decreased systemic vascular resistance and increased cardiac output in hyperthyroidism, a truly intricate symphony.
Amazing coordination. Lastly, lipid metabolism.
Thyroid hormone actively stimulates LDL receptors in the liver, crucial for clearing bad cholesterol. Also reduces apolipoprotein B levels.
So hypothyroidism leads to
High cholesterol. Hypercholesterolemia is a characteristic, very common feature. Precisely why checking thyroid function is often part of a lipid workup. An important connection.
Okay, building on those effects, let's dive even deeper into the specific disorders of thyroid function. Starting with hypofunction? Hypothyroidism.
Right. Known as myxedema when severe, it's the most common thyroid function disorder overall.
Cause? Still iodine deficiency worldwide.
Worldwide, yes.
Yes.
That remains the most frequent cause. But in non-endemic, iodine-sufficient areas, the vast majority of cases are due to chronic autoimmune thyroiditis Hashimoto's.
Hashimoto's. Autoimmune attack on the thyroid.
Exactly. Characterized by antibodies against thyroid peroxidase, sometimes thyroglobulin, leads to gradual destruction and failure of the gland.
That's primary hypothyroidism, failure of the gland itself.
Correct. Much less common is central hypothyroidism, diminished TSH stimulation due to a pituitary problem, secondary, or hypothalamic failure, tertiary. And of course, congenital hypothyroidism present at birth, that critical preventable cause of intellectual disability.
Symptoms are often nonspecific, you said.
Often very nonspecific, making diagnosis tricky without tests. Fatigue, lethargy, cold intolerance, mental slowness, depression, dry skin, constipation, mild weight gain, fluid retention, muscle ache, stiffness, irregular menses, infertility, overlaps with many things.
What about signs on examination?
Can include goiter, enlarged thyroid, but usually only in primary, bradycardia, slow heart rate, delayed deep tendon reflexes, coolsy skin, hypertension, non-pitting edema, facial puffiness.
And in infants, different signs.
Yes. Feeding problems, failure to thrive, constipation, sleepiness, and that irreversible mental impairment if not treated promptly. In childhood, it impairs linear growth and bone maturation.
So diagnosis really relies on labs.
Fundamentally, yes.
Right.
Given the nonspecific symptoms. Elevated serum TSH plus reduced or low normal free T4 for primary hypothyroidism. For central hypothyroidism, only decreased free T4. TSH might be inappropriately normal or low.
Okay, let's flip the coin. Hyperfunction thyrotoxicosis.
Yeah.
Caused by elevated free thyroid hormones.
Exactly. leads to that overactive metabolic state. Most common cause is an actual increase in thyroid hormone production, usually linked to TSH receptor stimulation and increased iodine uptake.
How do you measure that uptake?
With the 24-hour radioactive iodine uptake test, the RIIU, using 123I, a key diagnostic tool.
And what causes that increased production via TSH receptor stimulation?
Two main ways. Most common cause of high RAIU thyrotoxicosis, 60–90% of cases, is Graves' disease.
The autoimmune one.
That's it. Increased hormone production, diffuse goiter, and those IgG antibodies that activate the TSH receptor, mimicking TSH itself. Much more common in women, typically ages 20–50, often associated with other autoimmune diseases.
And the eye bulging. Exophthalmos.
Characteristic of Graves. An infiltrative ophthalmopathy, autoimmune inflammation around the eyes and muscle.
What's the other cause of increased production?
Autonomously functioning nodules, or toxic goiter. Here, somatic activating TSH receptor mutations cause parts of the thyroid to produce hormone independently, ignoring TSH regulation. Accounts for 10–40% of cases, more common in older patients.
Okay, those are high RAIU causes. What about low RAIU?
Low RAIU suggests no increased production. Instead, it points to thyroid inflammation or destruction causing a leak of preformed hormones or simply excess intake of thyroid medication.
There's also subclinical hyperthyroidism. Low TSH, normal T4, T3.
Yes. And even that milder form has consequences. Increased risk of atrial arrhythmias, excess cardiac mortality, excessive bone loss over time underscores the importance of even subtle imbalances.
Symptoms of overt thyrotoxicosis, driven by heat, motor activity, catecholamine sensitivity.
Exactly. Flushed, warm, moist skin, weak, tremulous muscles, rapid, forceful heartbeat, bounding pulses. Increased energy expenditure leads to increased appetite, but often weight loss if intake doesn't keep up.
Other common symptoms.
Insomnia, restlessness, anxiety, heat intolerance, frequent bowel movements. Older patients might have fewer sympathetic signs, apathetic hyperthyroidism, trickier to spot, can even see muscle wasting, thyroid myopathy. Most severe form is thyroid storm.
Diagnosing these, you said total hormone levels can be misleading because of binding proteins like TBG.
Correct. Total concentration changes with alterations in TBG amount or affinity. The gold standard is equilibrium dialysis for free T4, but that's complex, costly, not routine.
The common assays estimate free levels.
Yes, modern chemiluminescence and enzyme-linked immunoassays use labeled analogs, but even these can be influenced by altered binding proteins, non-thyroid illness, drugs. Careful interpretation is essential.
So the test of choice, if the pituitary is working normally.
Serum TSH measurement is often the test of choice. Why? Because pituitary TSH secretion is so sensitively regulated by circulating thyroid hormones?
TSH changes first.
Generally, yes. TSH is suppressed very low in thyrotoxicosis and elevated in primary hyperthyroidism, often before free T4 and T3 become clearly abnormal. Makes TSH an early and highly sensitive indicator. Invaluable first-line tests.
Okay, so if there's a problem, deficiency or excess,
Yeah.
how do we restore balance? Let's talk thyroid hormone preparations, mainly synthetic T4 and T3.
Yes, synthetic sodium salts of the natural isomers of T4 and T3 are used for therapy, chemically identical to what your body makes.
Let's start with levothyroxine. Synthetic T4.
Identical chemistry, identical mechanism of action to endogenous T4.
How's it taken? Absorbed. Excreted. The ADME.
Available orally tablets, liquid-filled capsules, and injectable. Oral absorption happens mainly in the stomach, small intestine, but it's incomplete, about 80% of a tablet dose.
Does timing matter?
Absorption is slightly increased on an empty stomach. Consistent timing, like first thing in the morning with water, leads to less TSH variability. Important for fine-tuning. Liquid-filled capsules might help if tablet absorption is poor.
How quickly does it peak?
Serum T4 peaks maybe 2 to 4 hours after ingestion, but because of that long half-life, about 7 days.
Daily dosing barely causes ripples.
Exactly. Barely discernible changes with once daily dosing. Missing one day has marginal effects. Patients usually told to take a double dose the next day if they miss one.
Can it be given IV?
Yes, if needed. Once daily, typically at about 80% of the daily oral requirement.
Any nuances with levothyroxine therapy? T4-T3 ratio?
Yes, an interesting one. For any given TSH level, the serum T4-T3 ratio is slightly higher in patients on levothyroxine compared to those with endogenous function.
Why is that?
Because normally about 20% of circulating T3 comes directly from thyroid secretion. That component is missing when you only take T4. The body relies solely on peripheral conversion.
Okay, now liothyronine, synthetic T3.
Identical to endogenous T3, sodium salt, available as tablets and injectable.
Absorption. Half-life.
Absorption is nearly 100%, peaks quickly, 2-4 hours, but the half-life is much shorter, only about 20 hours.
Meaning,
Requires multiple daily doses, typically 3 times a day, to achieve steady serum T3 levels. Can be a practical challenge for adherence.
how does the dosing compare to T4?
On a weight basis, required daily dose is about 1/3 of levothyroxine for equivalent TSH lowering. However, normalizing TSH with T3 alone requires an almost 2-fold higher serum T3 level compared to T4 therapy.
Why the higher T3 level needed?
Because the negative feedback on TSH normally relies partly on local T3 generation from T4 within the pituitary, that's less efficient or absent when only T3 is provided.
When is T3 used then?
Occasionally when rapid onset is desired, like in myxedema coma, where speed is critical, or if rapid termination is needed, like preparing thyroid cancer patients for radioactive iodine therapy.
But not ideal for chronic therapy.
Generally less desirable than levothyroxine for chronic use. More frequent dosing, higher cost, transient T3 elevations above normal range after each dose.
And theoretical concern.
Yes, that organs heavily expressing DIO2, relying on local T3 generation, might not maintain physiological intracellular T3 levels without plasma T4 as the substrate. Highlights why T4 is usually preferred as more physiological.
What about T4-T3 combination preparations?
They exist, mixtures of synthetic levothyroxine and liothyronine, often around 4.1 ratio by weight. Also desiccated thyroid preparations from animal glands containing both T4 and T3 in similar ratios, though not precisely matched to humans.
How does desiccated thyroid compare?
A 60 milligram or 1 grain desiccated thyroid tablet is roughly equivalent to 65 milligram levothyroxine in TSH lowering capacity. But as we'll discuss, their use is often debated. Levothyroxine monotherapy is generally preferred.
Okay, now we understand the preparations. Let's explore the crucial therapeutic uses of thyroid hormone. 2 main categories, right? Replacement for hypothyroidism and TSH suppression for thyroid cancer.
Those are the major indications, yes. Replacement is by far the most common use.
Let's start there. Thyroid hormone replacement therapy and hypothyroidism. Levothyroxine is the drug of choice.
Unequivocally, consistent potency, predictable absorption, prolonged action, very reliable, convenient once-daily dosing. It relies on the body's own DIO1 and DIO2 to convert T4 to T3 where needed, maintaining steady, physiological-free T3 levels.
What's the typical dose?
Average adult full replacement is about 1.7 millicitg body weight or 0.8 millicg pound, generally based on lean body mass for accuracy.
And the goal of therapy?
Twofold. Normalize serum TSH in primary hypothyroidism or free T4 in secondary tertiary, and relieve the patient's symptoms, restore well-being. Monitoring TSH usually suffices for primary hypothyroidism.
Does everyone need a full replacement dose?
No. Patients with mild primary hypothyroidism might normalize TSH with less, but the dose often needs increasing as their own gland function declines over time.
What about starting therapy in older patients or those with heart disease?
Cautious approach is best. Start sub-replacement, maybe 12.5, 50 milligauge a day. Increase gradually by 25 milligrams every 6 weeks or so until TSH normalizes. Follow-up blood test is about 6 weeks after any dose change due to T4's long half-life.
This brings us to that important question again, combination therapy. T4 plus T3 versus T4 alone. What's the verdict?
Well, the vast majority of well-controlled clinical trials conducted so far do not definitively support combination therapy being superior to T4 alone.
But some patients report feeling better on it, like desiccated thyroid.
Occasionally, yes. The reasons remain unclear. One double-blind crossover study found those who preferred desiccated thyroid actually lost a bit of weight on it, while TSH was kept similar.
So standard recommendation is still T4 alone.
Generally, yes. Monotherapy with levothyroxine is recommended as standard of care. It most closely mimics normal physiology, providing a stable T4 pool for the body to convert to T3 as needed.
But it's not a perfect mimic, right? That 20% direct T3 secretion is missing.
Correct. And the published studies comparing combo therapy to T4 alone do have limitations, which means it remains possible there's an undefined subgroup who would benefit from combination therapy.
Like people who still feel unwell despite normal TSH-T4, or those with that DIO2 polymorphism.
Exactly. Many trials haven't focused on those specific groups, and there haven't been large trials focusing on the DIO2 thionamides ala polymorphism. Plus, an ideal trial is hard to design, no long-acting T3, no prep matching the natural 11.1 T4.T3 secretion ratio.
So the bottom line for now.
The vast majority of hypothyroid patients feel well on levothyroxine monotherapy. and current evidence provides little robust support for a widespread benefit of combination therapy over T4 alone for the general population.
Okay. Now, hypothyroidism during pregnancy. This needs special attention, right?
Absolutely critical. Careful management is vital for both mother and child.
Why is a higher dose usually needed?
Several reasons. Increased TBG from rising estrogen levels binds more hormone. The placenta expresses DIO3, which inactivates thyroid hormone locally. And there's minimal T4 passage to the fetus early on, so the fetus relies heavily on adequate maternal levels before its own thyroid works.
And the risks, if it's not managed, overt hypothyroidism.
Increased risk of miscarriage, fetal distress, preterm delivery, and impaired psychoneural and motor development in the child. Even mild maternal hyperthyroidism might have subtle adverse effects. Optimal function is crucial.
So proactive management is key before pregnancy even starts.
Ideally, yes. As part of pre-pregnancy planning, adjust the dose to keep TSH in the lower reference range. Then advise women to increase their dose by about 30% as soon as pregnancy is confirmed.
Oh, like taking extra tablets.
Yes, for example, taking 2 extra tablets per week if they're on one daily anticipates the increased need. Being proactive is crucial because it takes weeks for levels to stabilize after a dose change.
And monitoring during pregnancy.
Monitor TSH frequently, especially early on, every 4-6 weeks through the first 20 weeks, then maybe less often. Adjust dose based on TSH, aiming for the lower part of the reference range. Revert to pre-pregnancy dose right after delivery. Check TSH again about 6 weeks later.
What about isolated hypothyroxanemia? Low free T4, normal TSH.
Some studies link it to subtle adverse neurocognitive development, but currently insufficient studies recommend routine treatment. Evaluation is complicated by binding protein changes and assay issues in pregnancy. TSH remains the best, most reliable test for thyroid status and monitoring treatment response during pregnancy. Moving to the most severe end, myxedema coma. Rare but life-threatening.
Yes, the extreme expression of severe, long-standing hypothyroidism, often in elderly patients, especially in winter. Precipitating factors.
Often infection, congestive heart failure, medical noncompliance, stopping medication.
Cardinal features.
Profound hypothermia, respiratory depression, decreased consciousness, potentially coma.
Treatment. Need to be immediate and aggressive.
Absolutely. 5e thyroid hormone advised, levothyroxine loading dose, 200-400 millicies, then daily IV, 50 to 100 millicies. Some clinicians add IV liothyronine T3 for faster action until stable.
Supportive measures too.
Critical: ventilatory support, passive warming, correcting hyponatremia, treating the precipitating cause like infection, and 5e glucocorticoids until coexisting adrenal insufficiency is excluded. Vital to cover all bases.
Now for the youngest patients. Congenital hypothyroidism. Success depends on early treatment.
Fundamentally, age at therapy start and speed of correction are critical. If treated within the first 2 weeks of life, normal physical and intellectual development can be achieved, an incredible outcome thanks to newborn screening.
Dosing for infants. Higher per kilogram.
Yes, initial daily dose of levothyroxine, 10-15 mg/kg orally, crushed tablets mixed with breast milk or water. Higher doses for severe cases to normalize T4 quickly.
Brand versus generic.
Any controversy. Mixed reports on bioequivalence in infants with severe congenital hypothyroidism. Some experts recommend against generic in this specific high-stakes situation to ensure consistency.
Biochemical goals. Monitoring.
Aim for free T4 in the upper half of the reference range, TSH in the lower half, though some infants maintain high TSH due to misset feedback. Frequent lab checks initially every 2 weeks, then less often over the first few years. More frequent if abnormal or compliance doubtful. Soy formula might impair absorption, needing dose increase.
Okay, shifting gears to thyroid hormone replacement and thyroid cancer. Different goal here. TSH suppression.
Yes, for well-differentiated cancers, papillary follicular, the mainstays are surgery, radioactive iodine, and levothyroxine, specifically to maintain a low TSH level.
Why suppress TSH?
Because TSH is a known growth factor for thyroid cancer cells. Keeping TSH low inhibits growth and recurrence.
What's the target TSH range? Is it agreed upon?
Optimal range is debated. No randomized controlled trials definitively settle it. A reasonable approach. Low normal TSH for low-risk patients without persistent disease. Mildly subnormal TSH, 0.1 MUL, for high-risk patients. More subnormal TSH, 0.1 MUL, for patients with persistent disease.
Balancing benefit versus risk.
Absolutely. Benefits of TSH suppression must be weighed against risks like osteoporosis and atrial fibrillation, especially in older or vulnerable patients.
What about thyroid nodules? very common, right?
Most common endocrinopathy, more frequent in women, usually asymptomatic, but can cause neck discomfort, dysphagia if large. Radiation exposure, especially childhood, increases risk.
Malignancy risk.
About 5% of nodules coming to medical attention are malignant. Most patients are euthyroid, check TSH. Diagnosis usually involves ultrasound and fine needle aspiration biopsy.
Treatment. TSH suppression for nodules.
Importantly, TSH suppression with levothyroxine is not recommended as general practice for euthyroid individuals with nodules. Little benefit, carries risks. However, if TSH is already elevated, then yes, administer levothyroxine to bring TSH into the lower reference range, correcting the underlying hyperthyroidism.
Got it. Let's cover general adverse effects and drug interactions for thyroid hormone therapy. Adverse effects only with overtreatment.
Generally, yes. Symptoms mimic hyperthyroidism, tachycardia, weight loss, anxiety. Specifically increases risk of atrial fibrillation, especially elderly, and osteoporosis, especially postmenopausal women.
And drug interactions.
Huh?
Lots can affect dosage.
Many can. Some increase dosage requirements. Drugs impairing absorption, antacids, bile acid sequestrants, iron salts, calcium maybe, PPIs. Drugs increasing metabolism, CYP3A4 induction, rifampin, phenytoin. Drugs impairing T4-ET3 conversion, amiodarone, glucocorticoids.
And some decreased requirements.
Yes, advancing age 65, androgen therapy in women. Careful TSH monitoring is crucial whenever interacting factors are introduced or removed. Best way to ensure optimal dosing.
Lastly, any investigational uses. New analogs.
Yes, exciting research. TRA-specific agonists are being developed. The idea is to target liver TRA-dependent processes like cholesterol without cardiac side effects, trial-mediated. Resmetirom is being investigated for non-alcoholic fatty liver disease.
And triac again, for transporter defects.
Right. The T3 metabolite triac, tiratricol, doesn't need MCT8-OATP1C1 for cell entry, studied for Alan Herndon Dudley, MCT8 deficiency, and used successfully for that OATP1C1 mutation patient. Shows potential where standard hormones fail due to transport issues. Molecular understanding leading to targeted solutions.
Okay, fascinating. We've covered replacement therapy thoroughly. Now let's shift focus to controlling excess thyroid function, anti-thyroid drugs, and other thyroid inhibitors.
Right, tackling hyperthyroidism. There's a whole array of compounds and strategies.
Like what?
The classic antithyroid drugs, the thyamides, directly inhibit hormone synthesis. Then you have ionic inhibitors blocking iodide transport. High concentrations of iodine itself have unique effects. And of course, radioactive iodine, which damages the gland. Plus adjuvant therapies for symptom control.
Let's start with the main antithyroid drugs, the thyrulines or thionamides. Propylthuracil, PTU, is the prototype.
Yes, their main mechanism is inhibiting thyroid hormone formation. They interfere with iodine incorporation into tyrosol residues of thyroglobulin and block the coupling of iodotyrosol residues, essentially inhibiting that key enzyme, thyroid peroxidase.
So they stop new hormone synthesis.
Exactly, depletes stored iodinated thyroglobulin as it's used up.
Is there a key difference between PTU and the other main one, methimazole, MMI?
Yes, a crucial distinction. PTU partially inhibits the peripheral deiodination of T4 to T3. MMI does not.
Meaning PTU reduces active T3 levels faster.
Correct. Provides a rationale for using PTU in severe hyperthyroid states or thyroid storm where rapid T3 reduction is vital.
Which ones are used now?
MMI and PTU are used in the U.S. Carbimazole, used in Europe, converts to MMI after absorption, so MMI is the active agent there too.
How do they differ in dosing and duration?
A small dose of MMI, 0.5 milligram, decreases organification, but 10-25 milligram is needed for 24-hour inhibition. PTU is absorbed rapidly, 20 to 30 minutes, but has a brief duration. 100 milligram dose wanes in 2-3 hours. 500 milligrams is inhibitory for maybe 6-8 hours. Requires more frequent dosing than MMI.
What about half-lives?
MMI plasma half-life is 4-6 hours. PTU is much shorter, about 75 minutes. Both concentrate in the thyroid, especially MMI, contributing to its longer action despite the plasma half-life, mostly excreted in urine.
Okay, therapeutic uses. Treating hyperthyroidism.
Primarily, yes, as definitive treatment for Graves, hoping for remission or for long-term control if preferred over other options, in conjunction with radioactive iodine to speed recovery, and to control the disorder before surgery, making the glands safer to operate on.
Which drug is preferred usually?
MMI. MMI is generally preferred for Graves' disease. Effective once daily, Better adherence, less toxic, especially lower risk of that rare but severe liver failure seen with PTU.
Starting doses.
MMI usually 15-40 milligrams a day. PTU starting dose 100 milligrams every 8 hours, maybe more frequent if dose is 300 milligrams a day. Reduced dose once euthyroidism is achieved, usually within 12 weeks, to avoid hypothyroidism.
How quickly do patients improve?
Usually within 3-6 weeks. Rate depends on drug dose, goiter size, initial T3 level, amount of stored hormone, turnover rate, and how completely synthesis is blocked. Careful monitoring is key.
Monitoring. Labs.
Monitor TSH, free T4, T3 every 2 or 4 months initially, then maybe 4-6 months once stable. Controlling hyperthyroidism usually shrinks the goiter and normalizes TSH. When TSH normalizes, decrease the drug dose significantly to avoid inducing hypothyroidism.
Historically, how were these discovered? Cabbage goiters.
Fascinating history. Observations of goiters in rabbits fed cabbage, thiocyanate precursors, then compounds like sulfaguanidine, phenylthurea found to cause goiters. Realization that these caused hypothyroidism despite gland enlargement from TSH stimulation. The primary action was inhibiting hormone formation. That opened the door to using them therapeutically for hyperthyroidism.
Okay. Side effects. Untoward reactions. Generally low incidences.
Relatively low, yes, but serious ones can occur. That fulminant hepatic necrosis with PTU, exceedingly rare, 1 in 10,000 adults, 1 in 2,000 children, but potentially devastating, requires liver transplant or can be fatal.
And a granulocytosis, low white cells.
Serious reaction, 0.1% to 0.5% risk for either drug, usually early on, first weeks, months, rapid onset, so periodic monitoring isn't helpful. Patients must be instructed to immediately report sore throat fever, stop the drug, get a granulocyte count, reversible on stopping. GCSF might speed recovery. Mild granulocytopenia needs frequent counts, could be thyrotoxicosis itself or an early reaction.
Common side effects. Rashes.
Mild urticarial papular rash is most common, often subsides. Less frequent. Joint pain, stiffness, paresthesias, headache, nausea, skin pigmentation, hair loss. Rarer but more severe. Drug fever, hepatitis, nephritis. Abnormal liver tests more common with higher PTU doses. Vasculitis, ANCA antibodies, seen in 50% on PTU, rarely MMI. Hypoprothrombemia bleeding with MMI.
What about thyrotoxicosis in pregnancy? Antithyroid drugs are the treatment of choice?
Yes. Radioactive iodine is absolutely contraindicated. Both PTU and MMI cross the placenta equally. Historically, MMI was avoided in the first trimester due to embryopathy risk. PTU preferred then, switching to MMI later due to PTU liver failure risk.
That's changing.
Yes. Recent recognition of PTU-associated embryopathy, especially urinary tract defects, not always obvious at birth, challenges this. Guidelines now recommend minimizing antithyroid drug use in the first trimester, weighing risks carefully.
Dose and goal in pregnancy.
Minimize dosage. Keep serum-free T4 index in the upper half of normal or slightly elevated, lowest effective dose. Graves often improves during pregnancy, but relapse common postpartum, so close monitoring needed.
Breastfeeding.
MMI, up to 20 milligrams daily, reportedly no effect on infant thyroid function via breast milk. PTU partitions into breast milk even less, offers options.
Okay, beyond direct antithyroid drugs, adjuvant therapy helps with symptoms.
Vital for managing symptoms, yes. No intrinsic antithyroid activity, just supportive.
Like beta blockers, propranolol, atenolol.
Highly effective. Antagonize sympathetic effects, tachycardia, tremor, stare, palpitations, anxiety, usually short-term until thyroid levels normalize.
And CAD2 plus channel blockers, diltiazem.
Can control tachycardia, decrease supraventricular tachyarrhythmias, also usually short-term. An alternative if beta blockers can't be used.
Any newer adjuvant approaches? Immunotherapy.
Yes. Rituximab, B-cell depleter, with MMI prolonged Graves remission in studies. And for advanced Graves ophthalmopathy, teprotumumab, IGF-1 receptor blocker, shows remarkable effects. 80% improvement. Huge advance for that complication.
Now, thyroid storm. Uncommon but life-threatening.
Exactly. Extreme complication of thyrotoxicosis. Usually precipitated by some intercurrent medical problem in untreated or partially treated patients.
Precipitating factors.
Infections, stress, trauma, surgery, thyroidal or not, diabetic ketoacidosis, labor, heart disease, rarely radioactive iodine treatment.
Clinical features, exaggerated thyrotoxicosis.
Yes. Cardinal features, fever, 38.5 degrees C, 101.3 degrees Warcardia, tachycardia disproportionate to fever, frequent, nausea, vomiting, diarrhea, agitation, confusion, can progress to coma, death in up to 20%. Critical emergency.
Diagnosis is clinical. Labs aren't uniquely different.
Primarily clinical, yes, based on severity of symptoms. Labs show hyperthyroidism, but not uniquely different from uncomplicated cases.
Treatment. Multifaceted, aggressive.
Immediate, comprehensive, supportive measures. 4V fluids, antipyretics, cooling blankets, sedation. Large doses of antithyroid drugs PTU often preferred here due to that Dia-1 inhibition, impairing T4 to T3 conversion peripherally for faster effect. Oral iodides after the first antithyroid dose, and crucially treat the underlying precipitating illness.
Okay, let's talk about ionic inhibitors. They interfere with iodide concentration.
Yes, anions that resemble iodide. Thiocyanate, perchlorate, fluoroborate. Monovalent, similar size charge?
Thiocyanate inhibits organification.
Yes, not concentrated by thyroid, but large amounts inhibit organification.
Perchlorate, ClO4, more active.
About 10 times as active. Blocks iodide entrance via NIS, can be transported by NIS itself. Inhibitory effects are additive with other NIS inhibitors, can control hyperthyroidism, but excessive doses, 2-3G daily, caused fatal aplastic anemia. Doses of 750 milligrams daily used for Graves, not available in America. Used diagnostically in perchlorate discharge test for organification defect.
Fluoroborate, BF4, also effective.
As effective as perchlorate.
And lithium, Li+, used for bipolar disorder.
Yes, it also decreases T4 and T3 secretion. Can cause overt hypothyroidism in some patients as a side effect.
Now, iodine itself, the oldest remedy. Paradoxical role.
Oldest remedy, yes. High concentrations have several influences. Limits its own transport, acutely inhibits synthesis, Wolff-Chaikoff effect, and importantly, inhibits hormone release.
That release inhibition is key clinically. Rapid effect.
Very important. Rapid, efficacious, and severe thyrotoxicosis. Direct effect on the thyroid. Works in euthyroid and hyperthyroid individuals.
How does it affect hyperthyroid patients?
Response often striking, rapid. Hormone release blocked, synthesis mildly decreased. Gland may get smaller, firmer, less vascular as colloid recumulates. Maximal effect after 10-15 days.
Does it fully control it? Permanently?
No, it doesn't completely control manifestations, and the beneficial effect disappears eventually, the escape phenomenon.
So clinical uses. Pre-op for thyroidectomy.
Yes, makes surgery safer. Also used with antithyroid drugs and propranolol for thyrotoxic crisis storm, rapid symptom control.
And protection from radioactive iodine fallout.
Crucial public health use. Stable iodine, 30 to 100 milligrams daily, significantly decreases thyroid uptake of radioisotopes. Uptake is inversely proportional to serum stable iodine, saturates the gland.
Preparations. Lugol's solution. KISS.
Strong iodine solution. Lugol's 5% iodine, 10% Ki, 8 milligram iodine drop. Potassium iodide saturated solution. KISS, 50 millijoule drop.
Doses for protection.
Typical doses, 1636 milligram, 2 to 6 drops. Lugol's or 50 100 milligram, 1 to 2 drops. KISS, 3 times daily. OTC products, ThyroShield generics, available for radiation emergency. Adult dose 130 milligrams every 24 hours as directed by public health.
Can iodine cause problems? Iodine-induced hypothyroidism.
Yes, euthyroid patients with underlying thyroid disorders can develop it when exposed to large amounts of iodine in drugs like amiodarone, idoquinol, contrast agents. They may fail to escape the Wolff-Chaikoff effect.
And untoward reactions to iodine.
Sensitivity.
Marked sensitivity in some. Angioedema, laryngeal edema can be life-threatening. Cutaneous hemorrhages, serum sickness-type reactions, fever, joint pain.
Rare.
Rare but severe. Thrombocytopenic, purpura, fatal periarteritis nodosa attributed to iodide hypersensitivity.
Chronic intoxication, iodism. Symptoms related to dose duration, brassy taste, burning mouth throat, sore teeth, gums. Increased salivation, runny nose, sneezing, eye irritation, head cold. Pulmonary edema, possible. Enlarged tender salivary glands, skin lesions, sometimes bizarre ioderma, gastric irritation, diarrhea, fever, anorexia, depression. Symptoms disappear within days of stopping iodine. Severe symptoms treated by promoting chloride excretion, diuretics, salt loading, to clear iodide faster.
Okay, let's talk about using radiation itself as a tool. Radioactive iodine.
A unique and powerful approach. Main isotopes are 123I and 131I.
123I for diagnosis, short half-life.
Yes, 13 half-life, gamma emitter, ideal for diagnostic scans, minimal tissue damage. 124I also used with PTCT for precise dosimetry in high-risk cancer.
And 131I for therapy, longer half-life, beta particles.
Exactly. 8-day half-life emits gamma rays detectable and beta particles. Therapeutic effect. 99% radiation expended within 56 days. Used for thyroid destruction, overactive enlarged glands, and in thyroid cancer, ablation, metastatic disease.
That doesn't work. Behaves like stable iodine.
Chemically identical. Rapidly trapped by thyroid, incorporated into iodomino acids, deposited in colloid, slowly liberated. The key is the destructive beta particles originate within the follicle, acting almost exclusively on thyroid cells with little damage to surrounding tissue. Highly targeted. Gamma rays pass through, allowing external quantification. Effects are dose-dependent, complete destruction possible.
Therapeutic uses? Hyperthyroidism? Diagnosis?
Widest use in hyperthyroidism and diagnosis. Clear indications. Older patients with hyperthyroidism, those with heart disease, Graves persisting recurring after surgery or failed drug therapy, toxic nodular goiter, sodium iodide 131I, oral capsules for therapy, 123I for scanning.
Treating hyperthyroidism with 131I.
Valuable alternative adjunct. Need to ensure stable iodide hasn't been used recently, precludes uptake. Pretreatment 24 uptake scan 123I ensures sufficient uptake for ablation. Optimal dose varies, 8150 mesogram, usual total dose 415 millici, aiming for maybe 8 millici delivered based on uptake.
How quickly does it work?
Symptoms gradually abate over 2-3 months as radiation destroys cells. Retreatment needed if inadequate. Assess failure with free T4T3, not just TSH initially. 80% cured by single dose, 20% need 2, few need 3 plus BLEC. Beta blockers, antithyroid drugs can help control symptoms during this waiting period.
Advantages. Spare surgery. Cost.
Spares surgical risks, discomfort, lower cost. No hospitalization usually needed in U.S. Patients maintain usual activities, though limit exposure to young children, pregnant individuals.
Disadvantages. Hypothyroidism is common.
Chief consequence. High incidence of delayed hyperthyroidism, often permanent, requiring lifelong levothyroxine, trading one problem for an easily managed one, usually.
Cancer risk.
Overall cancer death rate not increased, but some studies suggest small but significant increase in specific cancers, stomach, kidney, breast tissues that also express NIS, needs ongoing vigilance.
Radiation thyroiditis.
Can induce thyroiditis with release of preformed T4T3. Usually asymptomatic, but can worsen hyperthyroidism, rarely trigger storm. Pretreatment with antithyroid drugs reduces this risk.
Contraindications. Pregnancy.
Absolutely contraindicated in pregnancy. Fetal thyroid concentrates isotope after first trimester, causing damage. Best avoided even in first trimester due to radiation effects.
Use in children. Controversial.
Yes, theoretical concern about neoplastic changes. Data insufficient. Many clinics reserve for patients older than 25-30. Conservative approach.
What about thyroid carcinoma? Need TSH stimulation for uptake?
Yes, most well-differentiated carcinomas accumulate little iodine on their own. TSH stimulation is required to treat metastases effectively.
How is TSH stimulated? Hormone withdrawal.
Endogenous TSH stimulation. Withhold thyroid hormone replacement, for example, 4 weeks for levothyroxine to get TSH30 MIUL. Can use liothyronine, shorter half-life, during first half of withdrawal to minimize symptoms. Then give ablative 131I dose, 3150 plus MCI, repeat scan later.
Alternative. Recombinant TSH?
Yes, recombinant human TSH, rhTSH, thyrotropin alpha, can be used instead of withdrawal. Prepares for ablation or testing uptake thyroglobulin secretion without stopping levothyroxine and inducing hypothyroidism. Big advance for patient comfort.
Finally, chemotherapy of thyroid cancer. Rapidly evolving field, kinase inhibitors.
Very rapidly evolving. New therapies targeting driver genes. Important practical point. Levothyroxine requirements often increase with protein tyrosine kinase inhibitors, so need careful TSH monitoring.
For papillary and follicular carcinomas, surgery, radioiodine, TSH suppression are first line.
Majority treated that way, yes, but a small fraction progresses despite this, making systemic therapy with kinase inhibitors appropriate.
Guided by mutation testing.
Ideally, yes. Personalized medicine. Rare NTRK fusion genes. Treat with specific inhibitors. Larotrectinib, entrectinib for NTRK, selpercatinib, pralsetinib for RET. Limited data suggests better tolerated, maybe more efficacious.
If no NTRK mutations.
Multikinase inhibitors like lenvatinib or sorafenib target VEGF receptors, among others, can prolong progression-free survival, but complete response is rare. Lenvatinib often considered first line based on trial data.
BRAE 600E mutation, common in papillary.
Most frequent driver mutation. The murfinib, the brothinib inhibit this kinase, have efficacy, but not clearly superior to multikinase inhibitors generally.
What about redifferentiation therapy, making tumors take up iodine again?
Interesting concept. BROF V600E, NTRK fusions, or RAS mutations activate MAP kinase pathway. Treating these cancers for weeks with BRAF inhibitors, if BRAF plus, and or ME inhibitors, tramitinib, silumetinib, can restore radioiodine uptake in some tumors. Facilitates subsequent 131I therapy, optimal situations still being defined. Active research area?
Anaplastic thyroid cancer, very aggressive.
Highly undifferentiated, highly aggressive, 6-month average life expectancy. Devastating. Local disease treated with surgery, radiotherapy if feasible. Chemotherapy approach ideally guided by tumor mutation profiling. Combination dabrafenib plus trametinib, FDA approved for BRF V600E harboring anaplastic carcinomas.
And medullary thyroid carcinoma, MTC, different origin, parafollicular cells.
Minor fraction of thyroid cancers, yes, from calcitonin-producing cells. Sporadic or part of MEN2 syndrome, autosomal dominant, germline RET mutations in inherited MTC, somatic RET common in sporadic.
Treatment limitations, no radioiodine or TSH suppression.
Correct. Don't originate from follicular cells. First line is surgery.
Targeted therapy for MTC.
RET-driven MTC progressing after surgery can be treated with selective RET kinase inhibitors. Selpercatinib, pralsetinib appear safer, maybe more efficacious. Multi-kinase inhibitors, vandetanib, cabozantinib, also efficacious, prescribed without regard to RET status. Offers options.
Wow, what a journey. From microscopic synthesis, intricate chemistry, precise regulation, all the way to profound body-wide impact on growth, development, metabolism, every organ, and its complex array of disorders and cutting-edge treatments.
It really covers a vast landscape.
It's truly a testament to the incredible intricacy and vital importance of this tiny but mighty gland. I genuinely hope this deep dive has given you that shortcut, that elite, professional-level understanding of just how critical this system is.
Understanding the intricacies really provides a profound perspective on health.
Absolutely.
And this raises an important question, doesn't it? Given the thyroid's pervasive influence, touching nearly every cell, every system, and the body's elaborate, multi-layered mechanisms to create and regulate it, what does this profound interconnectedness mean for how we approach health and disease more broadly?
What do you mean?
It really underscores the wisdom of looking at the body as an integrated whole, not just isolated parts. It's a powerful reminder that often a small imbalance in one seemingly minor system can ripple throughout the entire body, affecting everything from your mood to your heart rate to your cholesterol levels.
That interconnectedness is key. A fantastic point. And with that, we wrap up another deep dive. We sincerely hope this exploration has given you a whole new appreciation for the tiny but mighty thyroid gland and its vast influence on your life. Keep learning, keep questioning, and keep diving deep.